Welcome to those that are joining. We'll be getting started here at the top of the hour. If there's demographic questions that pop up, please go ahead and answer those while we're waiting to get started. I'd like to welcome everyone today to a really exciting talk by Dr. Sara Gianella Weibel. We'll be talking about cytomegalovirus suppression, improving immunologic and functional aging outcomes in populations undergoing HIV treatment. You can see content on the web board members that are listed here. And next slide, please. Any financial or disclosures for the presenter, moderator, and planners and reviewers are listed here. Next slide. The IAS-USA designates this live activity for a maximum of 1.2 CME credits. This webinar is also approved for 1.25 hours of ABIM MOC credits, nursing, pharmacy, and pharmacotherapy. Generous support for this activity has been received by the following contributors that are listed here. A separate window will pop up for the poll questions when those come up in a few minutes. The chat is open for general discussion among the different attendees, but the presenter and the moderator, myself and Dr. Weibel Gianella, cannot see those. So please submit questions using that Q&A button. If you forget, our support staff behind the scene will help to remind you to put those back in the Q&A session. We also have to ask you to include your full name and institution with each of those questions, or we're not able to address your question. We will try to get through as many questions as we can, but we apologize in advance if we're not able to address all of the questions in the time allotted. Next slide. With that, and I would like to introduce our speaker today, Dr. Sara Gianella Weibel. Dr. Gianella Weibel is a professor of medicine at UC San Diego, where her research centers on HIV persistence and aging, with a particular focus on cytomegalovirus, or CMV, as a driver of inflammation and age-related comorbidities. She leads NIH-funded studies and clinical trials examining how CMV-driven inflammation accelerates physiologic decline in people with HIV. She also co-directs the Last Gift Rapid Autopsy Program, which she recently presented on, providing unique insights into HIV reservoirs across tissues. And with that, I will turn it over to you, Sara.
Thank you so much, Christina, and thank you everyone for inviting me here again. I'm actually excited to be here and to talk about, again, one of my favorite topics, the impact of cytomegalovirus on the immune system and morbidity in people with HIV. Why is this topic so close to my heart is because when I started working on HIV research, which was like 16 years ago, and I came to the US for my postdoc, my absolute first project that I started working on was on trying to measure cytomegalovirus in the genital secretion and then associate it with various outcomes. And I spent the first 5 to 6 to 7 years of my career measuring CMV everywhere and looking at various correlation. And now 15 years later, we have clinical trial going on, and it's a very unique and exciting opportunity to really be able to, through my lifetime or my career, to be able to see like the story to go from the beginning of the bench work and bring it all to the clinical trial. So this is why I'm really excited about telling you the whole story, how this unfolded over these many years working on it. Okay, so I do not have any financial relationship, and these are the learning objective. So we will, so we are describing the role of asymptomatic cytomegalovirus replication and how it connects to inflammation and immune dysregulation. And then I will summarize the key finding from our most recent clinical trial that we ran through the ACTG, which has very exciting results. And then we can discuss a little bit future direction and how this might open the door for new therapeutics in people with HIV and also beyond HIV. So this is our pretest question 1. So which of the following mechanisms best explain how cytomegalovirus contributes to morbidity in people with HIV despite suppressive antiretroviral therapy? A, cytomegalovirus induces massive expansion of CD8 T cells, promoting chronic immune activation and inflammation. B, cytomegalovirus directly increases HIV replication through integration in resting CD4 T cells. C, cytomegalovirus suppresses interleukin-10 signaling, enhancing inflammatory cytokine cascade. And D, cytomegalovirus is limited to the central nervous system, driving neurocognitive complications. So we will learn about this during my presentation. Okay. Okay, well, not bad. Not sure how to improve this. So it looks like you know some stuff already here. So pretest question 2. Which of the following drug has activity only against cytomegalovirus and not against other herpes viruses? Ganciclovir, foscarnet, valganciclovir, letermovir. A little bit more of a distribution here. Okay, thank you, everyone, and let's get started. So it's important to note that despite the fact that we have done incredible progress in addressing and improving life expectancy in people with HIV, up to for today, there is still a life expectancy gap between people with and without HIV, and this is particularly true in people that have lower CD4 T cell count or start antiretroviral therapy later after HIV acquisition. And, you know, this in average, there is still like a 9-year gap in survival. And there is also a gap in comorbidity. This means how many years a particular individual can you know, live without having any chronic morbidity. And we know that this gap also exists in people with HIV. And again, this is particularly true for people with low CD4 T cell count. And here we are talking about, you know, cancer, cardiovascular disease, and diabetes, all these aging-related disease that tends to appear earlier in people with HIV. So what we know is that inflammation strongly predicts morbidity and mortality in people with HIV, even when they are suppressed on antiretroviral therapy. And we have known data from almost 10 years ago, but there have been many papers showing that if somebody has higher inflammation, it does translate in more morbidity and mortality. And here in this figure, you can see, you know, if you stratify level of inflammatory marker in quartile, you know, like higher inflammation, more there is associated mortality and morbidity. And what we really would like to do is to move as many people as possible from the top 2 quartile, like the red and the orange, into the bottom 2 quartile, the green and the blue. So we have data from people without HIV, as in the general population, showing that inhibiting inflammatory pathways can improve some of these outcomes. For example, this is a study. Again, these are people without HIV that shows that inhibiting interleukin-1 beta has decreased significantly cardiovascular disease and also cancer mortality, in particular lung cancer. This is kind of a proof of concept that inflammation is indeed associated with some of these negative outcomes. But in this particular study, there was also an increase in death for sepsis. And this is not surprising, right? Because the immune system is kind of a balance. And if we decrease inflammation by impacting the immune system, we might also accidentally can impair the immune response towards pathogens. So it's always, every time we manipulate the immune system, there are always pros and cons to consider. So over the last years, there have been multiple attempts to reduce inflammation in people with treated HIV. For those of you that are familiar with the ACTG, where we run a lot of clinical trial in people with HIV, there is a particular group that it's called comorbidity group, and we have been running all sorts of intervention, but really there has not been a lot of successful intervention until recently, where with the GLP-1 agonist that show some promise, and then some of the CMV drugs, which I will show the data today. What is important to note is that another large ACTG trial, Reprieve, was able to show that giving statin to people with HIV, even people that would usually not qualify for statin, can reduce cardiovascular risk events by 35%, which is huge, right? Like, so this was a large study. It was over 5,000 people, and it was actually stopped early because the effect was so big that eventually everyone was taken off study and everyone was put on statin, right? There was a huge effect on cardiovascular disease, but so far we didn't see effect on cancer or other aging-related disease. And in fact, there was a significant but small increase in diabetes. And what is important to note is that the statin effect was really mediated to a decrease in lipids and not in inflammatory marker, right? So because there was no significant decrease in marker of inflammation in Reprieve. So this means that, statin have been, amazing, and they obviously can do a big difference in cardiovascular disease in people with HIV. In fact, right now the guidelines have changed, and a lot of doctors prescribe many more statin, but there is still a residual risk, which is important to address, and it is likely to be mediated by this increased inflammation that still persists in people with HIV. And this is where CMV comes in, right? Cytomegalovirus is a herpes virus, and it's ubiquitous. And almost every person that lives with HIV also lives with CMV. And we know that in people with HIV, even when they don't have any symptoms, there is a lot of asymptomatic shedding of cytomegalovirus. And this is mostly at mucosal sites, right? For example, in oral, in saliva, in the genital secretion, in the gut. And here are data from a cohort that I ran again in 2017, so a long time ago, where we can see that if we take people with HIV and we collect semen longitudinally, and these were all people with conserved immune system, over 80% at some point have detectable CMV in genital secretion. So this is important because even if people don't know, they have a lot of CMV replication going on. And this kind of engage the immune system in a very unique way. And over time, CMV can really drive a very big immune response towards CMV. And usually it increases with age, and it's even higher in people with HIV. In fact, in some people, 30 to 50% of the entire T cell repertoire can even be directed towards CMV. So you can imagine with all of the virus and the antigen that someone sees, like 1/3 of the whole T cell could be directed towards CMV. So that's crazy. It's very unique that CMV can do that. And cytomegalovirus doesn't only affect, the CMV-specific immune response. In fact, it can increase the general inflammation and all bystander cells. And there have been many papers from myself and many colleagues that have really shown that in people that have HIV and CMV, there is an increase in CD8 T cell counts and multiple inflammatory marker. And this is a paper that we wrote together with Mike Freeman, again in 2014, where we saw that there was this big difference in soluble TNF receptor 2 between people with HIV with HIV and with and without CMV. And I want to, I want you to pay attention to soluble TNF receptor 2 because we will discuss it later as we basically picked it as the primary outcome of the clinical trial, also based on this data. So there have been multiple, mostly observational studies that linked cytomegalovirus to adverse outcome. This is just a non-exhaustive list showing that cytomegalovirus DNA in plasma has been associated with AIDS-defining events. The immune response towards CMV has been associated with non-AIDS events, with cardiovascular disease, with neurological complication, with cancer, and with HIV reservoir. I do want to remind everyone that the vast majority in the past for many years have been observational, and so it was always hard to know which one was the chicken and which one was the egg, because one can argue that people that have CMV could have more inflammation and more negative outcome, but it could be the other way around, and maybe people that have more inflammation and cardiovascular disease that are sicker, and so they are more likely to also have CMV replication. So despite there was a lot of observational evidence, for a long time, we were just not sure about the directionality. Here I want to show you some specific study linking CMV or CMV immune response to negative clinical outcome. These are data from the ICONA cohort in Italy, and they showed it was a large cohort where they were able to show that people that had CMV IgG were, predicted non-AIDS event, but not so much, AIDS-associated events. The strongest effect was on cardiovascular disease. These are data from Priscilla Xu. She was at UCSF at the time, and she showed very nicely that having a higher CMV-specific CD8 T cell response was associated with thicker mean carotid intima media thickness, which is a marker of more arteriosclerosis. These are data that were presented at CROI from Peter Hand's team, showing that there was some association between higher cytomegalovirus antibody response and some type of cancer. And these are some data from my colleague here at UCSD, Scott Letender, showing that higher cytomegalovirus IgG titer were associated with neurocognitive impairment in treated HIV. There have been multiple studies, and there have been also evidence showing association between cytomegalovirus and psychiatric disease like depression and anxiety, and also association with imaging, changes in the brain imaging, like brain atrophy. So there are quite a bit of evidence. And in 2011, Peter Hand was able to do this small pilot trial where he took people with HIV. Most of them were treated and suppressed, and they had T cell count. And he did a placebo-controlled trial with valganciclovir to block CMV replication, and he was able for the first time to show that there was indeed a decrease in CD8 T cell activation in people on valganciclovir. So, and obviously this was very exciting at the time because this was the first evidence that was suggesting that cytomegalovirus was an active driver of inflammation and not just a bystander effect. Obviously, this study was meant to be a pilot trial for multiple reasons. One of them being that valganciclovir is not a very well tolerated drug, and it has a significant side effect, and so he didn't feel comfortable to, treat people with HIV for a long period of time. And so this was like an 8-week study, and then he was measuring, and then he followed people for another 4 week of drug. And another important point, which will be important, is that valganciclovir is not specific to cytomegalovirus. It also treats basically all other herpes viruses. So again, here it gives us some nice hints, but much more needed to be done. So here are some of the other inflammatory markers which were measured in the valganciclovir trial. You see we selected soluble TNF receptor 2, which, as I mentioned before, is the one that we selected for our clinical trial, and then soluble CD163 and soluble CD14, which are both monocyte activation marker. And you can see there was really a significant decline in the valganciclovir. So based on published data, if this effect was true, it will correspond to a 22% decrease in myocardial infarction and stroke, and up to a 50% decrease in diabetes type 2. So this is huge, right? This is basically the strongest intervention, even more than statin. But as I said before, valganciclovir is a pan-herpes virus drug. It doesn't suppress only CMV. So at this point, we were not sure if CMV was really the only virus involved in all of these immunological changes. So I wanted to give you a little bit of a overview. So I think most people are familiar. We have ganciclovir and valganciclovir, which are the oral and IV drug, and foscarnet, which are used in the clinic, cidofovir for resistant CMV, and then we have Letermovir, which is approved as CMV prophylaxis in transplant recipient, which the unique about Letermovir is that it's really specific for CMV, while the other 4 drugs are broader. And then maribavir for refractory or resistant CMV infection. I don't think it's used very often, and it has some side effect. But out of all of the drugs available, when we designed the clinical trial, we felt the Letermovir was the one that was safest for a long-term prophylactic. And here is the trial that we designed as part of the ACTG. And basically, I was the chair of the trial together with Peter Hunt from UCSF. And the primary goal of this study was to assess whether Letermovir therapy for 48-week reduced plasma soluble TNF receptor 2, which was the primary endpoint. And then we measured a bunch of other inflammation and cardiometabolic indices versus no anti-CMV treatment in people with HIV on suppressive antiretroviral therapy. It is important to note that this was an open label study and not placebo-controlled, even if that's what we really wanted to do, because at the moment we were ready to start the trial, the company had discontinued the placebo, and so there was no option for us to get the placebo unless we wanted to pay for it, which was obviously not within the budget. So we ended up having to have an open label design, not blinded design. So I already mentioned soluble TNF receptor 2, which was our primary immunological outcome for the intervention. The reason why we picked it, it was that, first of all, as I showed you below, before, it is increased in CMV in people with HIV. It does predict many of the outcomes that we are interested in, like cardiovascular disease, diabetes, and cancer. It was suppressed significantly by valganciclovir, and it's also relatively easy to measure because it's an ELISA. And so obviously, primary outcomes in clinical trial needs to be extensively validated. And so if a marker is easy to measure, it makes it easier. So, and here is like an overview of the study design. As you can see, we basically participants were randomized between Letermovir 480 milligram a day or antiretroviral therapy only for 48 weeks. And then we had another 12-week on antiretroviral therapy alone. And then I wanted to point out that also we enrolled people on suppressive antiretroviral therapy. Everyone was older than 40 years because we wanted to kind of try to have a little bit of an older population, which we hypothesize will have a stronger effect. And then we wanted half of the population to be with low CD4 T cell count and at least 1/3 women. And because we hypothesize that both of these categories will likely respond or have a stronger effect. And so we really wanted to maximize the chance to see a strong effect. And so it was not easy to enroll, as you can imagine, but the ACTG clinical site did a fantastic job. And then the team also wrote multiple grants to the NIH to add some extra endpoint. In fact, we had R1 where we were measuring artery inflammation via PET-CT. We had a grant sponsored by Merck where we wanted to do fat biopsy. We also had another R1 to measure gastrointestinal immunological endpoint doing gut biopsy. And then we had lumbar puncture, in fact, like because we wanted to try to get the maximum out of it. And at the point, the ACTG was a little bit concerned about the complexity of the trial and also the cost associated. And so they required a futility analysis. This means that until after the first 40 participants reached week 8, we had to stop enrollment. And then we waited until we had all of the sample, and then we generated soluble TNF receptor 2 and also soluble 163 to see if there was an early effect. So here I show you the characteristic of the participants that were enrolled up to the futility analysis. As you can see, like we did have about 1/3 female sex at birth, and a little bit less than half were with lower CD4 T cells. We ended up using 39 participants to our per protocol analysis because there was a few participants that were disqualified because they used some prohibited medication during the study. And I think the first good news is that Letermovir was very safe. So we had some lower grade adverse event like diarrhea and headache, and we had some higher grade adverse event, but they were all not related to the study drug. So I will say that overall, Letermovir was safe, and we didn't have anyone discontinue the treatment because of safety concern. And then another good news is that Letermovir did indeed suppress cytomegalovirus shedding. So as part of the study, we collected saliva and genital secretion and rectal swabs. And basically, it got completely suppressed, except in 2 occasions, but there was a significant decline. And we also measured CMV in plasma as a safety endpoint, because just to make sure that we did not select for any resistance, and we had no CMV DNA detectable in plasma at any time point. So at this point, after all of the people arrived to week 8, all of our 40 participants, we measured soluble TNF receptor 2 and soluble CD163. And when we got the results from the futility analysis, we were obviously very disappointed because there was an unexpected increase in soluble TNF receptor 2 and basically no effect on soluble CD163. And at this point, based on this data, the ACTG had a meeting with the safety monitor people and dates, and the decision was made to interrupt the trial, not for safety reason, that's important, for futility. And they allowed, so all the participants received a letter, they had to stop taking Letermovir, and then we were able to follow them for 1 more month while they were off trial, off a study drug, sorry. Obviously, we were really disappointed, but we were also intrigued because, if there was no effect, it would have been, disappointing, but there was not much to do about it. But here we basically saw the opposite effect. And what it's interesting that this is not the first time, there have been evidence in the literature about CMV having some unexpected effect on the immune system and also on outcomes in people without HIV. In fact, there is a large study where they showed that there was a qualitative difference between CMV and EBV on the effect on multiple sclerosis, where in fact cytomegalovirus was associated with a 30% decreased chance of getting multiple sclerosis, while EBV was associated with an increase. There was also a study of long COVID from the UCSF group, which was found that being seropositive for cytomegalovirus in people without HIV was associated with a 50% decreased risk of neurologic long COVID, while EBV was associated with an increased risk. So what we hypothesized is maybe cytomegalovirus, the relationship between cytomegalovirus and the immune system is just not as straightforward, but cytomegalovirus might have an immune regulatory effect on the immune system. And our main hypothesis was interleukin-10, because interleukin-10 is it's a cytokine that everyone has, that human produce, and it basically suppresses inflammation. This means it acts like a brake on the immune system, so that if somebody has an infection, an inflammatory marker go up, the body can produce IL-10 and try to break it, right? So that it doesn't get out of control. And CMV and EBV have learned to produce their own IL-10, which is very similar to the human IL-10, but it's viral IL-10. And they basically use it at their own advantage to modulate the immune system so that they can survive in the human body. And what is really interesting is that the CMV viral IL-10 acts stronger than the human IL-10 and can activate the IL-10 pathway stronger than the human one. So what we hypothesize is that maybe CMV was kind of immune modulating the human immune system through the IL-10 pathway. And so we went back and we measured human and viral IL-10, and then also IL-10 receptor. And what we saw is that there was indeed a decrease in IL-10 receptor with no change in human IL-10. And we were not able to measure viral IL-10 in blood because it's most likely that cytomegalovirus is replicating in tissue. And so it's unlikely to find viral IL-10 in blood. But like this result with a decrease in the IL-10 pathway and no change in human IL-10 might be an indirect evidence that viral IL-10 has been having an effect on the IL-10 pathway. And so here is a figure that we put together to try to kind of show this complicated relationship. It looks like cytomegalovirus has a double sword effect on the immune system. On one side, it's increasing inflammation. On the other side, it's decreasing TNF production so that the So this is why we believe that very early on, we saw this increase in the inflammatory marker. So basically suppressing viral IL-10 is like taking the foot off the brake of the immune system. So when we went back and we measured TNF receptor 2 on those people that were followed for a longer period of time, and some people made it to week 48. In fact, we saw that there was this spike at the beginning, and then there was a steep decrease, and it was significant at week 48. There were very similar pattern for other inflammatory marker. And for some marker, which included IL-1 beta, there was a decrease right away and then a sustained decrease over the whole study follow-up. So obviously, you know, like we are excited about this data. We are disappointed because the study was terminated and it should not have been. And we learned a lot about futility analysis, and we also learned how it's very hard to have a picture of how the immune system, you know, acts only based on one single cytokine, right? It's just much more complicated, and CMV is just a very complicated virus, and there is not one single way to measure its effect. So, and I want to remind everyone, IL-1 beta was indeed linked to cardiovascular disease and cancer in the CANTO trial, but you know, the CANTO trial ended up not going anywhere because of the increase in sepsis. And what we think is, could suppressing CMV be a safer way to reduce IL-1 beta without having the sepsis adverse outcome? So at this point, we also measured proteomics. We used like a very broad Olink panel, and we were able to see that, in fact, there was a very profound effect of multiple biomarkers in the Letermovir arm, and many of them were associated with endothelial dysfunction and arteriosclerosis. And we got really excited because we found this article from 2023 where these people used a very unbiased statistical method to try to find inflammatory genes that predict cardiovascular events in treated HIV. And they came out with 5 hits. And out of these 5 hits, 3 were indeed decreased in our marker. This is kind of an independent validation, and you know, gives us hope that there might be something there. And because like these are 2 completely independent study, and out of, you know, hundreds and thousands of hundreds of marker, we kind of narrowed it down to, you know, at least 3 of them that were causally associated with cardiovascular disease. And here you can see these are the 5 markers that were associated in the other trial and the 3 that were indeed decreasing in Letermovir. So we then measured CMV-specific IgG titers over time, and you can see there was a decrease in the Letermovir arm. And then when people stopped, you can see that the IgG started increasing again, despite the fact that CMV was suppressed the whole time. So it looked like probably the immune system were starting to sense the virus, but it was still controlled. So maybe if we follow people longer at some point, it likely will come back. But 12 week, at least for 12 week, it stayed suppressed after stopping Letermovir. And then we looked at various other outcomes. Here, the CD4-CD8 ratio, which is a very important marker that some people use also in the clinic, and it has been associated with morbidity and mortality in treated HIV. And you can see there was an increase in the CD4-CD8 ratio. What was really exciting is that this was particularly true in people with lower CD4 T cells. There was also a trend towards a bigger increase in women than men. And then when we saw at the CD4 T cell count, you can see here on the left that there was a significant increase in people that start with low CD4 T cell count. And this is really exciting because these are basically the immunological non-responders. These are people that, despite being on suppressive antiretroviral therapy, they just can't get the CD4 T cell up. And we know that these people also have the highest mortality and morbidity. And there is really no intervention so far that was helping them boost the CD4 T cell counts. And so it's incredible to see that there was an increase in CD4 T cell count, which is clinically significant. We then also measured a lot of flow cytometry T cell marker. So we saw that there was a decrease in CD4 T cell and CD8 T cell activation. So we saw that there was a decrease in senescent cells. These are like very differentiated cells that are older in the immune system. And we know that senescent cells, that they have a harder time respond to some of the antigens. So and it looks like, treating CMV decreases level of senescent cell. We were also able to show that Letermovir decrease activated senescent cell, which we hypothesize are, really enriched in CMV-specific T cells. Actually, we know that they are enriched in CMV-specific T cells. And then what makes it even more exciting is that as part of this clinical trial, we added some functional measures. So but Kristine actually was the one that advocated to add some of this functional measure of frailty. And one of them being the 5-time chair raise test, which is a very well-established frailty measure where people need to, sit and stand up 5 times as fast as they can. And then we measure how long it takes. And it's a very good predictor of, muscular strength. And what we saw is that, in fact, people that were on Letermovir had a significant decrease of 1.8 seconds in the 5-time chair raise time. And even if it looks like it's short, it's actually really significant. And to the best of our knowledge, the only other intervention that had a significant decrease that was comparable in size was exercise. And you can see there was also a significant correlation between the change in time and some of the inflammatory marker, which really, it looks like there is like a mechanistic explanation. Okay, so these are kind of our conclusion of the clinical trial is that suppressing cytomegalovirus has decreased mucosal shedding, not only during treatment, but also for at least 12 weeks post-treatment. There was this transient increase in some inflammatory marker, which we interpret that probably it was kind of a effect of the immune modulation that CMV does, but overall, on the long term, that was a really decrease in many inflammatory markers that were associated with cardiovascular and cancer risk. There was an increase in CD4-CD8 ratio and a raise in CD4 counts in those people that were immunologic non-responder, and there was a decrease in T-cell activation and senescence. And really exciting, there was an improved physical function in terms of test. And these immunologic improvements seem to be better in women and people with low CD4 T cell count. But obviously, because the trial was cut short, we were not really powered to see a full effect. So the clinical implications are unclear, but we do believe that this might be the most promising immune-based intervention yet for treated HIV. And it's not overlapping with statin, right? So they will be complementary. So additional consideration. So I think it's interesting to see that CMV remains suppressed for 12 weeks after stopping the study drug. That's something like the mechanism, we don't know why. But I think this is interesting, especially it has clinical implication. If maybe someone doesn't want to take an additional drug for the rest of their life, maybe there is like a pulse therapy strategy. So we are right now doing some differential study between Letermovir and valganciclovir to see why there was such a big immunologic difference, which we hypothesize probably because valganciclovir suppresses more than only CMV. One important learning point is also the whack-a-mole effect when we target one inflammatory pathway, how it can do good and bad at the same time. And really maybe targeting CMV can be a safe way to reduce IL-1 beta or IL-6 in a way that doesn't necessarily, have the effective events like increasing sepsis. And then obviously there was a lot to be learned about conducting futility analysis. Now in retrospect, it was not the best approach. And probably right now we just lost a lot of time because obviously what we saw at the beginning of the trial was in no way predictive of the long-term effect of the study drug. And so I have a lot of people that I want to thank. Peter Hunt, who is the co-chair, and Kristine is also part of the study team, but David Smith, who is my mentor, and a lot of people across all of the ACTG sites and the funder and the study participants. And I think that's it. So I wanted to go back to our questions and see if you learned something new. Okay, I think if I remember correctly, it was 81 to 92, so that's great. And then the next one. Okay, yes, so the A is the correct answer. Like, as I said, like cytomegalovirus really, drives this huge expansion of T cells and also produces inflammation, which are associated with the adverse outcomes. And then this is the second one, which one is only active against CMV and no other herpes virus. Perfect. Yay. Good job. We're done.
Really fantastic talk, Sarah. That was a lot of fun. Great to see all the tremendous work that came out of that study. There's some questions in the chat, and then I have some questions that people had put in ahead of time. So I'll start with some trial-specific questions that people had. Christine Somas from France was wondering what medications were prohibited within the Letermovir trial and why, if you happen to remember, if there were any key medications that couldn't be used.
Well, that's a good question, and I don't remember from the top of my head. I know that Letermovir has some interaction with some study drugs, which includes high dosage statin, for example, and then obviously all of the immune modulatory drugs that would kind of impact the outcome of the trial, like high dose steroid or immunosuppressive medications.
But lower dose statin was still allowed.
Yeah, lower dose status
Okay,
was
yep.
yes. But it had mostly to do with either drugs that will confound the results or that were having an interaction with Letermovir.
Another question was, for the clinical trial, did participants have to have active CMV at enrollment, or did you screen for CMV IgG positivity, or what were the requirements to get into the study?
Yeah, that's a very good point. In fact, we did discuss about it. Like we screened for CMV IgG because obviously we wanted everyone to be seropositive, which, as I mentioned, like the vast majority of people with HIV are seropositive for CMV, but there is like a 3% people, and we didn't want to enroll them. But we decided against actually looking for active shedding. First of all, because it's not so easy. And second, because it's so intermittent that even if someone comes in and we find CMV in saliva, it doesn't mean anything, like maybe 2 weeks after it's gone. So we also wanted to make sure that the intervention was more generalizable. So because of all of these facts, we decided against, having a CMV, shedding requirement.
And did you happen, I don't know if this analysis was done, but did you happen to look at the CMV IgG in people who didn't have a decrease? Were there some that didn't change at all for their CMV IgG? I know the mean or the median decreased, but if there was a non-responder.
So that's a good point, and I don't think we've done that analysis, like to really go and see if people that had more or less shedding.
And yeah, I don't know if it would have changed or not, but okay. And then there's some interest in kind of this statin and CMV effect, and whether Shelly for example, wondered if you foresee a future study where letermovir and statins might be used together. And I think there's some early data that suggests that statins may also have a little bit of an anti-CMV effect. So just kind of elaborating on that potential CMV statin interaction and how letermovir may be used in conjunction.
Yeah, no, that's a very good question. And in fact, I do think also what we hypothesize is that statin and letermovir or any anti-CMV effect will be very synergistic. And I know there are some in vitro statin effect. I don't think it's really strong enough. I do think that in my mind, like when we get to the point that we can do a phase 3 trial, it would be really nice to see how, with a very large sample size, if we can really stratify and see how the combination of letermovir and statin works together. So I don't think right now we are still at the phase that we are trying to design another early stage trial to confirm and to fully enroll without a futility analysis. But I do think that it will be nice to have a combined one. You said there is no difference in CMV IgG outcome in Reprieve. That's a good point. Is it true, Christine? I think you wrote that paper, right? That the CMV IgG did not.
We haven't looked at change in CMV IgG. It was just based on baseline CMV IgG.
CMV IgG is just a very easy way to screen. But as I said, like, I think the CMV story is so much more complicated than just CMV IgG that I'm not surprised that based on only that marker, you couldn't see an effect. I think we might have to just do a much more in-depth dive into CMV DNA and immune response, including T cells.
And kind of in that same vein, Dr. Dubé was wondering why CMV might have a greater pro-inflammatory or pro-comorbidity effect in people with compared to people without HIV. So what's unique in people with HIV in terms of CMV?
Well, that's a good question. I do think that it's because HIV has a hit on the immune system. There is, and we know there is much more CMV shedding in people with HIV. So just CMV has more opportunity to replicate in various mucosal sites and then have a stronger impact on the immune system. And I think it's bidirectional, right? CMV hits CMV, like HIV hits CMV, and then CMV kind of hits HIV, and then you create kind of a circle, which, when you suppress HIV, you partially break, but at that point, CMV is already kind of unleashed, and it keeps having this effect.
Some questions that came in before the webinar today were sort of related to what's the next step. So I think both from a clinical trial standpoint and then just thinking bigger picture of how do you foresee this potentially being implemented in the future? Like, certain subpopulations that you'd use it in? Would you use it in everyone? And then is this something that well, we won't talk about cost at all, but I think some of the big picture of like next steps first from a clinical trial standpoint, and then sort of thinking to the future of how you might roll it out in clinic.
No, that's a good question. And in fact, we are already in discussion, right? Both with Merck and the ACTG to basically resume the trial. Our goal is to redesign a very similar trial like we wanted to do at the beginning with about 180 participants. And right now that we have seen that we have a strong effect on the chair raising, I think we were actually thinking to do maybe like a more in-depth dive into friability with more different effects, and also maybe some muscle biopsy. And I think that will be the immediate next step, really to kind of confirm and maybe do some surrogate endpoint. But the idea would be then to have a large clinical trial, like a reprieve type clinical trial with 5,000 participants, and really see if we can see an effect. And I do think that a stratification will be great. Like as we saw in our small trial, it looks like people with low CD4 T cell and women might have the strongest effect. So it's likely that we might not have to treat everyone. Maybe there are some people that would have the most advantage. I know Letermovir is very expensive right now, but that's also because there is not a big market for it. I think if we decide that we will want to do and treat, thousands of people, the price will go down, and also the patent on Letermovir is expiring at some point. So I see that there is a lot of possible future direction coming out of this data. Exciting, actually.
Oh, that's great. I think there were a couple more specific questions too, just about the drug itself. And when you think of Letermovir, I think there was a question about if this is a short-term treatment, or if someone who initiated Letermovir would have to be on it for life if this was a treatment for CMV. So how do you envision that moving forward too? Is it an intermittent treatment, or is this a lifelong therapy?
That's a good question. And obviously, at this point, we don't know yet. The fact that CMV was indeed suppressed for at least 12 weeks points that maybe we don't have to do it for life. Maybe you can do, a short treatment and then see how CD4 affects and then do a break. It might be in combination with something else, or in combination with a CMV vaccine, which, we have a trial right now as part of the ACTG with the CMV vaccine, which we don't know yet how it worked, but I think it's too early to know exactly how it will look like. I think it's just a very promising intervention.
And then I think that there's a question in the chat too about reconsidering what we're doing for CMV suppression, particularly in people with low CD4 count, slightly related to your talk too. But now that we have such a safer drug with Letermovir. Do you think that I mean, in terms of safety that you saw in the trial, do you feel confident that this is kind of a safe trial move or safe drug moving forward, that maybe there is more of an opportunity to kind of think about how we're prophylacting people with advanced HIV unrelated to the aging aspect?
No, that's a very good question. And based on the data of our trial, which obviously is small, it was very safe. We didn't see any drug resistance emerging, which was a concern at the beginning. So I think that that's a very good question, something that might need to be reevaluated.
And then there was a question about the role of other herpes viruses in HIV and aging. So, I mean, obviously your talk has been really focused on CMV, but is there any evidence that other herpes viruses like EBV or HSV may also accelerate the aging process in people with HIV?
I think there are definitely evidence. Right now, obviously, we have been focusing on CMV because CMV is where the strongest evidence lie. I do believe that there is a cumulative effect as well. Like more pathogen you have on board, more your immune system is stressed, and it probably has an effect on aging. So, and EBV and herpes simplex in particular, right? I think there are definitely evidence, especially with EBV, both in people with and without HIV, that has been associated with various diseases. So I agree, right? Like I don't think I think CMV is unique because of the very strong effect it has on the immune system, which no other virus has. But this doesn't mean that there are not other contributor. And again, like the cumulative effect, like the fact that people with HIV often have, multiple occurrence of STI, and like everything kind of hits a little bit the immune system anytime. In fact, I think that there are some data about how pediatricians have, for example, lower CD4, CD8 ratio compared to. No, it's
because of all the viral exposures.
it's not clinically relevant, but I do think that people have recurrent infections over the lifetime could have a hit on the immune system.
And just to the audience, we have a couple minutes left. If you have any other questions, please make sure you put them in the Q&A with your name and institution so we can get those answered. There was a question about whether there's an effect of Letermovir on the HIV reservoir. Was that looked at all in the Letermovir study, or do you know if there's any data?
We are looking at it. In fact, we have one of the other ones was looking at the HIV reservoir. I would have hypothesized, if anything, more on the, of the residual transcription. No, I don't know if, like, maybe not an effect on the, the size of the HIV DNA, but if we really improve immune dysfunction, I will say maybe there is an effect on residual HIV RNA, and that's what we're doing right now. So
okay. And then do you know if there's, I think it's in the works as well, but any data on the risk for cancers in people with HIV? Obviously, something that we didn't see much of a change of in Reprieve, so not as much of a statin effect, but do you know if there's anything with CMV and Letermovir?
So obviously in our particular trial, we didn't have any cancer, I think. And if we had one, but I do think there is definitively evidence that it could affect cancer based on the immune pathway that we saw were, affected by Letermovir and some of the earlier epidemiological data that I showed. So I do think that it's very possible that it could affect cancer. And this is why I think it's exciting as complementary intervention to statin.
Yep. No, I think that's a really interesting next direction. So I think last question, unless anything else pops up in the chat here in the next minute, but I warned you I would ask you about physical function. So I thought that was a really interesting outcome when we know that CMV is associated with frailty in other populations. So what are your thoughts for why that might have happened? Do you think it's through changes in inflammation or other ideas on why we might have seen that improvement in physical function?
Thank you for the question. It's funny that you didn't ask me the question, but in fact, we discussed about it. So I know the answer, mostly because she told me. We have, like it could be multiple. We think we have multiple hypotheses, and it could definitely be a direct effect on the immune system, or maybe also like the cardiovascular. We hypothesize that there might be a direct effect on the muscle, and this is why we would love to be able to do muscle biopsy, at least on a subset on participant for the future trial, because we know that CMV can replicate in muscles, and maybe there is some local inflammatory and effects that could be affected. So I think that the mechanism is not clear, but it could be multifactorial, and this is what we would love to find out with our future trial.
Yeah, and I don't think I've seen anything with CMV, like muscle biopsy, looking at treatment for that in the general population. So it'll be really novel for the field in general. So
Yeah,
great.
exactly. So I really hope we can do it, and so then we can, there is a whole new line of investigation, which the whole frailty we didn't even think about when we designed the first trial. We were mostly focused on cardiovascular, neuro, and metabolic. But then right now, obviously we are excited about frailty, and so this is why we kind of shifted a little bit right now the direction.
Well, this was fantastic. It's really exciting to see this data come to life, and hopefully can continue to move forward with more investigations in Letermovir for and other pathogenesis of CMV and aging outcomes. And then I think we have just a couple final wrap-up slides here. While the slides are coming up, I'll just put in a plug. I don't know if it shows up on here, but there's a fantastic program on HIV and aging for the non-geriatricians that we'll be having in a couple of months. We'll talk a little bit more about frailty for those that are interested. But evaluations and information on how to claim your CMV will come by this afternoon or by this evening. Your feedback is super important, so please fill that feedback out. Next slide. And then if you haven't seen it yet, there's a really interesting supplement that was in Topics of Antiviral Medicine, which has phenomenal pictures, great for teaching and great for education. So please check that out. There's a couple other presentations that will be coming up, the podcasts that are going antiviral, hosted by Dr. Sag. One recent one on demystifying syphilis, so listen in on these podcasts. A upcoming webinar next week on clinical considerations for women with HIV during menopause. You can see the information here. Another one for HIV care for displaced persons in the US, also already available on demand. The annual HIV update in person in Chicago that you can see information here to sign up. Really phenomenal full day program. And then the course that I mentioned, Medical Management of People with HIV as They Age, a course for non-geriatricians. We'll have sections, lots of discussion on aging, epigenetics, screening for people with HIV, immunizations, and mental health disorders. So a nice follow-up to some of the things we talked about with CMV today. Next slide. And I think the recording should be available within 24 hours, as you can see in the chat. So just again, a huge thank you to Dr. Sara Gianella Weibel for her presentation today. For those of you who attended, and thank you for the questions from the audience as well. We look forward to getting your feedback. Have a great afternoon.